A 67-year-old man I treated came into my office on a Tuesday afternoon. He was sharp, active, still working part-time. His wife had packed him a pill organizer, 7 medications, all prescribed by different specialists, all considered safe. By Thursday morning, he was in the ICU, not because of one pill, because of what happened when 5 of them met inside his aging body at the same time. If you are over 60 and you take more than 2 medications, or even just one over-the-counter pill alongside a prescription, what I am about to share with you could be the most important thing you watch this year. Stay with me, because by the end of this video, you will know exactly which combinations your body cannot survive and what to do instead. My name is Dr. Kevin Adewale, and I have spent over 2 decades working as an experienced medical professional, seeing patients across internal medicine and geriatric care. I have stood at bedsides when families ask me, "How did this happen?" "He was fine last week." And the honest answer, more times than I am comfortable admitting, is this: it was the medications. Not one of them alone, but the combination. The invisible, dangerous interaction that no single prescription label warns you about. I have reviewed hundreds of clinical studies, combed through the research in Harrison's Principles of Internal Medicine, cross-referenced findings from the New England Journal of Medicine, and I have watched these patterns repeat themselves in real patients, real families, real lives. I am not here to scare you. I am here to prepare you, because knowledge is the only thing standing between you and a preventable crisis. Here is something most people never think about. The body you have at 65 is not the body you had at 35. And I do not mean that in a motivational sense. I mean it in a deeply biological, pharmacological sense. When you are young, your liver and kidneys process medications with speed and efficiency. Your cytochrome P450 enzyme system, that is the network of liver enzymes responsible for breaking down drugs in your body, runs at full capacity. But after 60, that system slows down. The kidneys filter blood less efficiently. Liver blood flow can decrease by up to 40%. Body fat increases relative to muscle, which changes how fat-soluble drugs are stored. And here is the part that should concern every single senior watching this. What was a safe dose for your 45-year-old body can accumulate to toxic levels in your 67-year-old body, even if you have been taking the same pill for 20 years. Dr. David Sinclair, in his landmark book Lifespan, describes cellular aging not as a gentle slowdown, but as a cascade. Systems that once compensated for each other begin to fail in sequence. The same is true for drug metabolism. 1 medication might be manageable, 2 might be borderline, 3, 4, 5, taken at the same time, and you are creating a chemical environment inside your body that no physician designed and no pharmacist automatically checks for. And the tragic part? Your doctor may not have time to tell you this. A 10-minute appointment is not enough time to map the interaction profile of 5 different drugs prescribed by 3 different specialists. That responsibility, by default, often falls on you, and that is exactly why you are watching this right now. Let's get into the list. These are the 5 most dangerous pill combinations seniors take every single day, often without any idea what is happening inside their bodies. Item 1. The silent bleed, blood thinners plus NSAIDs. Most people skip this one and regret it, and I mean that literally. I have seen this send patients to emergency rooms from what started as a simple headache pill. You have been told that ibuprofen is safe. It is over the counter. It is in every medicine cabinet in America. Here is what the research actually shows. When you combine a common NSAID, that is a non-steroidal anti-inflammatory drug like ibuprofen or naproxen, with a blood thinner like warfarin, aspirin, or even the newer anticoagulants like rivaroxaban or apixaban, you are dramatically increasing your risk of a gastrointestinal bleed. Not a small risk, a clinically significant, life-threatening risk. Here is the biological mechanism. NSAIDs work by inhibiting an enzyme called QX1. That enzyme is responsible for producing a protective mucus lining in your stomach. When you strip that protection away and simultaneously thin the blood, you have an unprotected stomach wall and blood that cannot clot properly. If a small ulcer forms and it bleeds, your body has no backup system. In seniors, because gut motility is slower and pain sensation is sometimes blunted, that bleed can go unnoticed until the person collapses. Harrison's Principles of Internal Medicine, one of the most authoritative clinical references in the world, documents this interaction as one of the most common causes of preventable drug-related hospitalization in patients over 65. Not a rare event, a common one. The practical tip: if you are on any blood thinner and you need pain relief, speak to your doctor about acetaminophen as an alternative. It does not carry the same stomach lining risk. Never reach for ibuprofen or naproxen without checking first. Item 2. The pressure crash. ACE inhibitors, plus potassium supplements or potassium-sparing diuretics. I have seen this combination send 3 patients to the ER in 1 month, and every single time the family said the same thing. But they were both prescribed. How could they be dangerous together? You have been told that taking your blood pressure medication and your potassium supplement together is perfectly fine. After all, many blood pressure drugs are known to deplete potassium, so supplementing makes sense, right? Here is what the research actually shows. ACE inhibitors, medications like lisinopril, enalapril, and ramipril, actually cause potassium retention. They block a hormonal pathway called the renin-angiotensin-aldosterone system, which normally signals the kidneys to release potassium. When you block that pathway and then add potassium supplements or combine with a potassium-sparing diuretic like spironolactone, potassium levels in the blood can rise to dangerous levels. This condition is called hyperkalemia, elevated blood potassium. And in seniors, whose kidneys are already filtering at reduced capacity, it can happen faster than anyone expects. Why does that matter? Because potassium controls your heart rhythm. When potassium gets too high, the electrical signals in your heart become erratic. You can develop a life-threatening arrhythmia, an irregular heartbeat, without any warning. No chest pain, no dizziness beforehand. Just a sudden, catastrophic disruption in cardiac function. A landmark finding published in the New England Journal of Medicine showed that the combination of ACE inhibitors with potassium-sparing agents in elderly patients with reduced kidney function increased the risk of sudden cardiac death significantly, and that many of these patients had no idea their combination was dangerous because it was prescribed across 2 different physicians. The practical tip: if you are on an ACE inhibitor, ask your doctor specifically whether potassium supplementation is appropriate for you, and request a blood potassium level test before adding anything, even a natural potassium supplement from a health food store. Before I get to number 3, this next one surprises almost every patient I tell it to, because it involves a medication that millions of seniors take every single day and consider completely harmless. And items 4 and 5? 4 is the one cardiologists argue about most, and 5 involves a combination so dangerous that I personally consider it one of the top underreported threats in senior health today. Stay with me, because what is coming could genuinely change the way you manage your health tonight. Item 3. The muscle meltdown. Statins, plus certain antibiotics or antifungals. Number 3 is one that catches even well-informed patients completely off guard. You have been told that your statin, drugs like atorvastatin, simvastatin, or rosuvastatin, is safe for long-term use and that your doctor monitors it regularly. Here is what the research actually shows. When certain antibiotics, particularly clarithromycin or erythromycin, or antifungal medications like fluconazole, are taken alongside statins, they block the very liver enzyme, that cytochrome P450 system I mentioned earlier, responsible for breaking the statin down. The result is that the statin accumulates in your bloodstream at levels far higher than intended. And what does a statin do at toxic levels in the body? It damages muscle tissue. The condition is called rhabdomyolysis, the breakdown of muscle fibers, and it is not just painful. As muscle cells die and release their contents into the bloodstream, those byproducts travel to the kidneys and can cause acute kidney failure. In seniors, where kidney reserve is already diminished, this can accelerate quickly from muscle aches to organ failure within days. Dr. Michael Greger, in How Not to Die, discusses how the chronic use of statins in aging populations carries underappreciated risks, particularly when combined with other common medications, and emphasizes that the conversation about statin necessity versus lifestyle intervention is one that many patients are never offered. He makes the case that dietary and lifestyle changes can achieve significant cardiovascular risk reduction, a conversation worth having with your physician. The practical tip: anytime you are prescribed a new antibiotic or antifungal, tell that prescribing physician exactly which statin you take. Do not assume they already know. Ask them directly, is this safe to take with my statin? It takes 10 seconds and could prevent a medical emergency. Item 4. The memory thief. Anticholinergics, plus sleep aids or antihistamines. Number 4 is the one cardiologists, and increasingly neurologists, argue about most. And it is especially heartbreaking because the medications involved are ones that seniors reach for every single night. You have been told that a sleep aid is harmless, that an antihistamine for allergies is so mild it does not even require a prescription. Here is what the research actually shows. Many common over-the-counter sleep medications, like diphenhydramine, the active ingredient in Benadryl and Zezquil, belong to a class of drugs called anticholinergics. They work by blocking a neurotransmitter called acetylcholine. Now, acetylcholine is not just involved in sleep. It is one of the primary neurotransmitters involved in memory, cognition, and learning. When you block it repeatedly in an aging brain, a brain that already has reduced cholinergic reserve, you are accelerating exactly the kind of cognitive decline that families are terrified of. Matthew Walker, PhD, in Why We Sleep, one of the most important books I have read in the last decade, makes the point with devastating clarity. Sedatives like diphenhydramine do not produce natural sleep. They sedate the brain, and sedation is not the same as the restorative deep sleep your brain needs to consolidate memory and clear toxic waste products, including the amyloid beta proteins associated with Alzheimer's disease. So not only does this medication block acetylcholine directly, it also prevents the brain from performing its own nightly cleaning process. When you combine these anticholinergic sleep aids with other anticholinergic medications, bladder medications like oxybutynin, certain antidepressants, or even some blood pressure medications, the cumulative anticholinergic burden on the brain compounds. Researchers have a term for this, the anticholinergic load, and multiple studies have linked high anticholinergic load in seniors to significantly increased rates of dementia. Dr. David Perlmutter, in Grain Brain, explains how the aging brain is uniquely vulnerable to chemical assault, and that many of the neurological changes we attribute to normal aging are in fact driven by preventable exposures, including repeated pharmacological interference with brain chemistry. The practical tip: ask your doctor or pharmacist to calculate your total anticholinergic burden across all your medications. If you struggle with sleep, ask about melatonin, cognitive behavioral therapy for insomnia, CBTI, or magnesium glycinate, all of which have evidence behind them without the cognitive risk. Never take diphenhydramine as a regular sleep aid after 60. Item 5. The acid trap. Proton pump inhibitors, plus magnesium-dependent medications or B12-dependent processes. And now we arrive at number 5. And this one I consider one of the most underreported, most dangerous, and most quietly devastating combinations in senior pharmacology today. You have been told that your proton pump inhibitor, drugs like omeprazole, pantoprazole, or esomeprazole, is safe for long-term use, and that reducing stomach acid is simply a quality-of-life improvement. Here is what the research actually shows. PPIs, taken chronically, do far more than quiet heartburn. They fundamentally disrupt your body's ability to absorb two nutrients that are absolutely critical for heart function, nerve health, and cognitive integrity in seniors: magnesium and vitamin B12. Here is the mechanism. Stomach acid is required to cleave B12 from the proteins in food so that it can be absorbed. Block the acid long-term, and B12 absorption plummets. B12 deficiency in seniors causes peripheral neuropathy, that is nerve damage that produces numbness, tingling, and balance problems. And it can cause a type of cognitive decline that is indistinguishable from early dementia. I cannot tell you how many seniors I have evaluated for suspected dementia who were, in fact, profoundly B12 deficient from years on a PPI. But it does not stop there. PPIs also dramatically reduce magnesium absorption, a condition called PPI-induced hypomagnesemia. And magnesium is the mineral that regulates over 300 enzyme processes in the body, including the ones that control your heart rhythm. When you combine long-term PPI use with a diuretic, which many seniors take for blood pressure or heart failure, and the diuretic is simultaneously flushing magnesium from the body through the kidneys, you can arrive at critically low magnesium levels with startling speed. And critically low magnesium means an unstable heart. Dr. Jason Fung, in The Obesity Code, speaks compellingly about how modern medicine's tendency to treat symptoms, like acid reflux, with permanent pharmaceutical suppression, rather than addressing the underlying metabolic cause, creates cascading deficiencies that are rarely monitored or discussed with the patient. The heartburn was a signal. The PPI silenced the signal without addressing what caused it. The practical tip: If you have been on a PPI for more than 8 weeks, ask your doctor to check your magnesium and B12 levels today. Ask whether a dietary approach, H2 blocker, or lifestyle modification could reduce your need for the PPI. And if you must stay on it, discuss active B12 supplementation and magnesium monitoring. Your heart and your brain depend on it. Now here is the good news. Every one of these risks is completely preventable once you know what to do. I want to give you something you can act on starting today. I call it the SafeRx Review Protocol. 5 concrete steps that any senior can take right now to dramatically reduce the risk of dangerous drug interactions. Step 1. Create a complete medication list. Every pill, every supplement, every vitamin. Not just your prescriptions, everything. Over-the-counter sleep aids, fish oil, potassium supplements, antacids. Write it down with the dose and the time of day you take it. This list is your first line of defense. Step 2. Schedule a dedicated medication review appointment with your primary care doctor. Not a sick visit, a specific, focused appointment where the only agenda is reviewing all your medications together. Bring your complete list. Ask specifically, are any of these interacting with each other? Many physicians welcome this conversation. They simply do not have time to initiate it themselves. Step 3. Use a pharmacist as a second set of expert eyes. Your pharmacist has access to drug interaction databases that can cross-check every medication on your list simultaneously. This service is free at most pharmacies. As Dr. Michael Greger explains in How Not to Die, an empowered patient who asks the right questions is statistically far more likely to receive safer, more personalized care. Be that patient. Step 4. Ask your doctor to check nutrient levels if you are on long-term medications. Specifically request tests for magnesium, B12, potassium, and vitamin D. These are the nutrients most commonly depleted by the medications we discussed today, and correcting a deficiency is often simple, inexpensive, and life-changing. Step 5. Adopt a personal rule. Never add a new medication or supplement without checking for interactions first. The simplest way to do this is to use a free online drug interaction checker like the one at drugs.com, and then confirm with your doctor or pharmacist. 30 seconds of checking could prevent 30 days in a hospital. Now I want to hear from you. Which of these 5 dangerous pill combinations surprised you the most? Drop your answer in the comments right now. I read every single one, and your comment could help someone else who is watching this video and needs to hear it. If this video gave you value today, please share it with someone you love, a parent, a sibling, a close friend, anyone whose health matters to you. One share from you could genuinely save a life. And if you are not subscribed yet, hit that subscribe button right now. I publish new health insights every single week, the kind of information your doctor may not have time to explain in a 10-minute appointment. You deserve to know this. Medical disclaimer. The information shared in this video is strictly for educational and informational purposes only. It does not constitute medical advice and should not replace the guidance of your qualified physician. Always consult your doctor before making any changes to your health or medication routine.